without further ado, let's get started because we're just a little bit late. My name is Bevey Miner, and I am going to talk to you for a few minutes about interoperability during COVID, as well as interoperability after COVID. We've learned a lot during our COVID challenges right now in this pandemic. I've watched interoperability for the last 20 plus years. I've been in healthcare technology. I've been in digital health. I've led a lot of product strategy. I've done quite a bit of work in interoperability. I've worked with CMS to try and move along our interoperability standards. And I was instrumental in launching what we called the first RIOs, Regional Health Information Organizations, back then. So, it's hard to say that we've really advanced interoperability. These are some baby steps that we need to take, but it has become magnified under COVID, what is happening with our lack of interoperability. So what we're seeing is that it's a challenge for first-line responders, for instance, as an example, to be able to get information and data on patients that is critical when they have to make a triage decision. The patient, if you ask a patient, in the last year, have you had asthma, emphysema, bronchitis, suffered from any other potential pulmonary conditions, they, in many instances, would not know the difference between those diagnoses. And that's very critical when trying to make a triage decision, as an example. When you look at the back-end oversight teams, it again has become a challenge in really making sure that everyone that is touching the patient, caring for that patient, is seeing the same longitudinal record on that patient. And then as you look at, even in an ambulatory environment with specialists and PCPs trying to treat these patients, diagnose the patients, you have a lot of challenges in terms of interoperability and delivering the kinds of services and views into patient records that are already challenging this overburdened healthcare system. Because we entered this COVID pandemic with the challenges of interoperability. They weren't fixed in many instances. And so we're seeing these challenges even more and more magnified. So really, where does supporting patient-centered care through this interoperability and data sharing make a big difference? And I'll talk about some of those programs that we're going to put in place post-COVID, but where we've seen these silos of lack of communication, lack of care coordination, transitions of care, et cetera, have become a real problem under COVID. I mentioned that an individual longitudinal health record has been something that we've been striving for. And while EHRs will carry that longitudinal record, you may have a patient seeing a physician on Allscripts in one instance, Epic in another, NextGen in another, and those systems are not talking to each other. A common problem we have been talking about for over a decade. And when you look at data from within those episodes of care, or you could call that transitions of care, that's where we find errors happen in healthcare, is during those transitions from one care setting to another care setting, whether it's the hospital upon discharge and the primary care doc is trying to take over, even if it's a COVID follow-up treatment, it's very difficult to really have a smooth transition of care because the documents and the patient information is not really being served. The population health marketplace is really meant to be, it's items like contact tracing, which you have heard as a positive and a negative in many media articles today. Really just understanding where even things like pandemics and epidemics start to make a huge, big difference with our lack of analytics and looking at a total population. And population health, when we talk about it as a marketplace, it's not really meant to be a marketing place. It's looking at population health as well as how it interacts with public health. which is so important as we're now starting to see our public health entities enter a patient care modality in a way that we've never seen public health do before. You think of lots of times public health is managing the underserved market, but now public health is sitting front and center in trying to help manage this pandemic. And community health exchanges, as well as state health exchanges, national exchanges, are a place where we can look at providing additional support for getting access to patient information, but those exchanges have really been lackluster in interoperability in the past. So let's look at some of the options that we've already got in place that we're trying to make ubiquitous for interoperability today, as well as how important they will be in a post-COVID environment. Well, we have point-to-point integrations. That's been going on for quite a while. That's just, connecting the HL7 up to your lab. It may be connecting to an individual hospital. It may be a hospital and an acute setting connecting to a post-acute, but it really is point-to-point. And that's the way we've been doing interoperability for a long time. And that point-to-point used to have different flavors of integration technology and translation. We used to have challenges with semantic interoperability. That was just because everybody was working on a different dictionary and language of terms. I'm happy to say that the industry has really advanced to using common terminology, which is so critical when you talk about interoperability. As a very simple example, when you have a lab that looks at a glucose test and they use GLU, another lab may say glucose. When you have to do a diagnosis on glucose levels, we have to all be talking the same language. So what's really fabulous about that is we've created a common language for clinical terminology called SNOMED. We've got LOINC that has a common language for labs, and then we've also got the same thing as a common language for prescriptions. So we have created a world where point-to-point integration is working, but it's a web of point-to-point integration. So moving from just regular HL7, HL7 has moved to FHIR-based standards, which is the latest FHIR.4 is the standard that it was in the most recent final rule from CMS and ONC. That standard is the standard that everybody is now starting to move for. And we're looking at API integration. So when I say that the EHRs are not talking to the EHRs, some of that is really based more on policy and not wanting to share data. So finally, CMS has come out with the long-awaited, in the last 2+ years, information blocking final rule. And that is requiring that these systems have API integration so they can all talk to each other. So I think next year in post-COVID world, as we start to look at the implementation of CMS and ONC's final rule, which has been pushed back to next year for the deadlines, we'll start to see more and more of these interoperability solutions play out to be a very positive. Direct secure messaging has been around for a while, and there are all certified EHRs are going to offer you direct secure messaging, but many of the providers don't even realize that they have direct secure messaging. And secure messaging is one of the best ways that you can send information, not really blasted across the entire care team, but at least from provider to provider, referral management, and it's done in an electronic format, in a CCDA format, so it can be mapped back into the EHR. And it can be added to the longitudinal patient record. Everything that we are doing that touches the patient, keep in mind, true interoperability will add it to the patient's record. The other area that is starting to get more and more attention within a COVID environment that we have is the role of digital cloud faxing. And I will tell you that I represent J2 Global. J2 Global offers eFax, which is one of the largest cloud faxing, high trust certified faxing solutions that exist today. And more of that is starting to be used, particularly in these point-to-point models where you've got an article from the New York Times that is talking about hundreds and hundreds of paper faxes just spilling out of Harris County's fax machines. Well, you no longer have to do that in a cloud faxing modality. So if you think about the incremental moves up to making interoperability more efficient and more functional, cloud faxing is one of the first ones that you have to say, just get rid of the paper. If you get rid of the paper, go to a cloud faxing mode, look at how you can triage that cloud faxing, get it into the patient's record without having to scan and data enter. You've really taken a huge, big step to move forward in interoperability. 75% of all patient data is still being sent on paper faxes today. The other area that is really getting a lot more usability is care equality and Commonwealth. These are backbone capabilities and networks that allow you to do a query for more patient information. It's on demand. It's given to a care team to find out if the patient had an encounter that was not documented inside that electronic health record, or visible for a care team that needs to know if that patient was in the hospital in the last 30 days. So it's all of these different types of interoperability solutions really make a difference when it comes to the technology of it. I just got a text from Vincent. Thank you for adding that. But one of our very basic roadblocks, as you all know, if you've been working in interoperability, is identifying the patient. Back when HIPAA first came out, we removed the Social Security number for any clinical data. Cannot be attached to a patient's record. There have been numerous attempts in Washington to provide a medical number. They've all been shot down. So you are a different identifier in the electronic health record. You are identified as a lab order when you get a lab test done. You are identified as a member number when you interact with your payer. Just 3 examples, but they are numerous. We have created what we call master patient indexing, or EMPI. You may have heard it as that as well. So, Vincent, your comment is really pertinent because I was just talking about care equality and Commonwealth. One of the very basic ways that you can find a patient sitting in that in that network, that exchange, is by filling out a simple basic form: patient's first name, last name, maybe their zip code, date of birth, their gender, to be able to find that patient. But we have to do it based on a set of demographic codes, and then you will get a likely probability that this patient is who this patient is, and be able to see that information. Socialized governments have one patient number. The Department of Defense has a military number. And you see interoperability working more efficiently within those systems, but we don't today, because the way the American healthcare system works is that each of these different silos has you identified in a very different way. So thank you for that comment, because it is a roadblock that can be challenging for us. So let me summarize what a program that we just recently launched. And there are numerous ones out there that are trying to manage the challenge of interoperability. I gave you these standards that many of them, and I removed a slide because I don't have time for it, that will talk about how a lot of the direction in here is language in the latest CMS rule. Specifically, CMS talks about even electronic notification for admissions, discharge, and transfer. That's from a hospital system that has to notify the entire care team that a patient has been admitted, a patient has been discharged, or transferred to another care setting. CMS is saying that must be electronic. They are telling the industry, use whatever electronic means you see fit so that you can send a message, and there is a receiving end that can accept it. Left a little bit of ambiguity on specifics, but mentions as direct messaging, really tries to suppress the use of paper faxes to be able to share that information, and pushing for electronic faxing. So direct secure messaging can satisfy that. Digital cloud faxing can also satisfy that. And carry quality and Commonwealth are going to start to move to more of a push communication as well, not just necessarily an on-demand query. So let me talk about one type of solution that can meet the needs of the interoperability that I mentioned before, and also satisfy some of the CMS requirements and rules. When you have a certified EHR, much of what I'm telling you here today is already included. Not that a lot of the practitioners will use this. But when you have a certified EHR, you still have to ask yourself the question, why is 75% of all patient data still being sent on paper? When you look at the silos within the healthcare care settings and the patient's journey, those silos that were not incentivized under the Accountable Care Act to move to an electronic means of getting patient data, like an electronic health record, they weren't included in meaningful use. They found little reason to invest in these technologies because they were expensive and they weren't incentivized to do so in any way. And because meaningful use, which is now more under MIPS and MACRA, which are terms that, if you're aware of what CMS looks at for incentives, upgrading to the latest version of a certified EHR is additionally expensive year after year after year. So many of these different care settings where we see the problematic paper push is where you don't find this seamless integration of an ability to look at digital or electronic information coming into one common record. That would include post-acute care facilities, such as skilled nursing facilities, assisted living. Home health is becoming more and more important today as we are looking at reducing costs and at better health outcomes and trying to push patients home. Patients that are going home today are at a much higher acuity level than they ever have been before. You've got caregivers sitting right next to the patient that have to do wound care. Physical therapy is being done at the patient's house. We are discharging patients with acute surgery treatment within 24 hours, and we're sending them home. Home health is on a clipboard, a 3-ring binder with instructions. When you deliver a medication in a home health environment, you write it down in a little tab that says medications in a 3-ring binder. These are problematic settings. So this solution that we call Consensus, it was launched in 2020 with the attempt to launch it at HIMSS. Unfortunately, that didn't happen because we didn't have a HIMSS. But what this does is really provides an easy document management system and data sharing that you can integrate into an EHR, because there is the capability with API HL7 or FHIR to integrate some of these interoperability formats, but you don't need one. Because we have to figure out an incentive to move these paper silos to, if it's not going to be an electronic health record, it still has to be some platform that allows them to manage these documents and to be able to participate in creating that longitudinal record and getting access to that patient data. So the very first one is digital cloud faxing. I mentioned that before. It enables a healthcare provider to just move away from the paper and enhance that workflow. Sometimes faxes will include batches. 10 patients will come in under one fax. You have to painfully separate that into different patient records. A digital cloud faxing solution with the right kind of triage will allow you to do that all in a digital way. And administrators just love the ability to do that simply without having to scan and stand by a fax machine. And then you look at the movement to direct secure messaging. What's really fabulous is if you can match a fax number, because you're about ready to send a fax and it says, oh, did you know that provider you're faxing to has a direct secure email address? So send it in a direct secure messaging. So we're always trying to figure out, even in a cloud faxing mode, how we can promote direct secure messaging, because it is structured data in a CCDA. And then I talked a little bit about patient query. We are offering free carry quality queries during COVID right now for providers that need to find out if there was any other encounter that happened on a patient, which is really important before you're going to try and put together a care plan. And then I mentioned a little bit about exchange networks and health information exchanges that may be a part of a community, a part of a state exchange network, or even a broader cross-state exchanges. That we're trying to get better and better at having these exchanges become more functional. But if you don't have an electronic EHR that allows you to populate that exchange, you need a tool like Consensus to be able to do that. And one of the other things that I didn't have in this slide, but in a post-COVID environment, where we're starting to see huge adoptions of technology, are in areas such as virtual care. And when you have an episodic moment where you're being seen by a physician in a virtual care environment, it may be signed up with a primary care doc so you could just get a COVID test, or you're having a physician do some medications for you in a virtual care setting. If they are not in the environment of a common EHR, then that's going to be an episodic moment that will not be included in the patient's longitudinal record. I'm going to stop there because I've taken a little bit too much time and I've got some questions. So I think one of the questions is, what does interoperability look like in this, post-COVID moment? So I think, thanks, Kent, for asking that question, that it just so happens these CMS rules, the direction for CMS to push for greater interoperability will be, these deadlines are happening in 2021. A lot of pushback in the industry from almost every stakeholder that said, you can't expect us to look at new data blocking interoperability, patients getting access to more of their patient information, which is a huge interoperability challenge at the back end, while we're trying to treat patients in COVID. So it's going to be interesting to see how CMS's rules really start to change the dynamics of where we're going within interoperability. And all of that is going to be post-COVID. So my hope is that the industry starts to realize that we are in a huge, big, patient data sharing and patient record situation right now with this pandemic. We don't expect pandemics like this to happen, every other year. This is we hope a once in a huge, decades or multiple decades occurrence. But what it did for us is to just give us visibility to how bad the situation is. And luckily, we have CMS's final rule along with ONC's final rule from the Cures Act going to be implemented next year. So I think that with the sensitivity of how we all need to step up and make, create this digital environment, get rid of the paper as much as we can and the paper process. I think that nearing that with CMS's final rule and ONC's final rule will be extremely instrumental to finally see if we can make a big difference on interoperability. And I hope so, because I'm very passionate about this because my career has been centered around interoperability. So while there's a few minutes left, any other questions that you may want to chat to me so that I can answer them. Otherwise, you are more than welcome to send me a message. You have access to my profile card that was so great about what HealthIMPACT did. And please feel free to reach out to me. I think there was another question about identity management to trace and track patients back and provider access. A little bit more for the role of biometrics. We all know that we've got, chronically ill patients that we have to deal with comorbidities. So if you've got diabetic patients that can enter their daily glucose, they don't even have to enter it, goes to the cloud automatically, and can be, sent back to their provider, especially if it's out of normal, in an alert mode, then you've got a way to be able to access, patients in a remote way that a lot of these sensors or biometric or vital signs would have only been able to be attained if the patient was sitting in a counter in a physician's office. So I think we're going to see more and more of these start to become prevalent. A lot of startups created these solutions. One that comes to mind is AliveCore, as an example, had a 2-lead EKG that you could attach to the back of your smartphone. They didn't get a lot of traction because it was kind of, what am I going to do with this data and where do I go find it? And they didn't interact or integrate into an electronic health record. It was a separate dashboard that a provider had to go out to. Today, those companies are failed or they've had to shift their model. So I think the infrastructure for biometric sensor data it'll become more and more important because we're going to see the prevalence of these types of solutions for insight into a patient's almost immediate health state become more valuable. Any other, I'm keeping you a little bit over time, which I know you probably have some other sessions you might want to go to. This was recorded, so I'm not sure how you're going to be able to get access to the recordings, but I'm sure you'll get instructions for that. And please reach out to me again if you have some additional questions you want to know more about platforms and solutions like Consensus, or how an e-faxing solution can help you get to another level, at least a step up to get rid of the paper process within your ecosystem. I'll be glad to talk to you a little bit more one-on-one. So if there's no more questions, thank you again for your time. Sorry about our audio at the beginning. And I'll let you go on to your next session.